congratulations. That's a big milestone, I guess. You'll always be able to have that and carry it with you. So we're going to talk about prenatal testing today. And like she said, I'm Allison Achillefu. I have no financial disclosures. And why did I get chosen to talk about this topic? I'm a family medicine physician, so I've been trained in obstetrics and gynecology. Some people don't know, but family practice, you pretty much wide spectrum. So for residency, you're required to have at least 40 deliveries, and I had well over that. And you know, there's some family medicine docs that even do C-sections. So they're trained in that and are still doing C-sections, routine C-sections, as well as emergency sections. So I don't do any of those, but I have had deliveries and done a lot of prenatal care. And also personal experience, and that's my little baby girl up there.
Oh my God.
July 4th baby. So let's get into the first trimester. During the first trimester is where you're going to have a lot of your screening, and that's basically because you want to catch these things early. So the first thing is going to be your history and physical. I know that's not a test, but it's going to be a huge clue into what tests that you're going to order. I don't know how much OB you guys have had, so just shout at me if you know, and we can move forward. So basically your history, you're going to ask about pregnancy symptoms, breast tenderness, nausea, vomiting, amenorrhea, things like that. And then of course you're going to ask your last menstrual period, because that will tell you an estimated gestational age. And that's going to be all you have to go on until you get your ultrasound. So the next thing you're going to check is your past medical history. You know, if a patient has high blood pressure, diabetes, those types of things are really important in pregnancy. Obstetric history, you have your G's and P's. Do y'all know what G's and P's are? Yes? No? Okay, perfect. So total pregnancies, and then term, preterm, abortions or miscarriages, and then living children. Surgical history, if your mom has had any abdominal surgeries before and she potentially needs a C-section in the future, that's going to be really important to know. You might have to battle some adhesions there. Family history, this is where we get down into the nitty-gritty with the genetic disorders. I work at Oklahoma, OU's Health Sciences Center, and in our EMR there's a whole list. So I don't even have to memorize these things. You just click down the boxes, and you ask about different genetic disorders. Probably the most common one though is Down syndrome. You can ask about history of mental retardation as well. On to social history. So of course you're going to ask about cigarette smoking, alcohol use, what else? There's one more. Drug use, any drug use. But I put a special tab underneath because here's an important part in your history taking that you can potentially make a huge difference in somebody's life. And that's in the area of domestic abuse. And this has become more of a problem with human trafficking. I've actually known a physician that was able to help a teenager get out of a situation with human trafficking just because they asked this simple question. A lot of people don't feel comfortable. They're like, well, how do you ask about that? But really, all I do is say, do you feel safe at home? It's pretty simple. Don't have to feel awkward about it. Just ask the question. And then you're going to go through your review of systems. Again, genetic screening. We'll talk about advanced maternal age, which is AMA. And that's basically a pregnant woman over 35 years old. Infectious history. You're going to want to know about any STDs, including HIV and herpes simplex virus. That's the HSV. Any history of varicella. Congenital varicella is not very nice. So either a history of chickenpox or the vaccine. Ask about cat litter exposure because of parvovirus, and then hepatitis B. And these are almost all of those you're going to test for except for the varicella and cat litter. Again, substance abuse, we already talked about that. And then, of course, the lovely Zika virus that has come to bless us. Hopefully, we don't see a whole lot of this, but I was talking to Ms. Torres earlier, and I think we're going to see a little bit of it. I don't know how much exactly. Fortunately, I haven't had to deal with this at all yet. We have a pop-up in our EMR, and it's a specific questionnaire. All you do is ask, do you think you could be pregnant? If it says no, it lets you move past. If it says yes, you ask about certain symptoms like fever, sore throat, the malaise, flu-like illness. If it says yes and you've been to an endemic area, then you have to call the Oklahoma Health Department, and they'll help you draw the titers and let you know what exact labs that they want. And then your physical exam. So the physical exam for pregnant patients is a little bit different than for everybody else. You're going to add a few things. So the fundal height, you're going to check for edema on almost every exam, and that's to check for preeclampsia symptoms. You're going to do a pelvic exam at the very, very first visit, and then FHTs or fetal heart tones you're going to get after every visit, beginning around 10 to 12 weeks. So lab work, pregnancy test is number one. You've got to confirm that pregnancy before you can code or even bill for a pregnancy, right? So you're going to get that pregnancy test first, and then the basic labs are CBC, CMP, TSH. Congenital hypothyroidism is devastating in pregnancy, and that's basically from the iodine metabolism. There's a name for it, and I'm blanking right now, but it's basically cretinism, and it can cause cretinism, and that is basically a severe form of mental retardation. So the child is severely disabled their entire life. Excuse me, you're going to check for the sexual transmitted diseases, HIV, hepatitis B, RPRs for syphilis, and then we have gonorrhea, chlamydia, and wet prep down there as well. HSV, I have a question mark by that, and that's pretty much, I don't get that with every pregnant patient. Now, thinking about my patient population, maybe I should, but I don't, and I just asked of symptoms. Have you ever had an outbreak before? Have you ever had burning, tingling sensation down there and you just didn't get it checked out? If they say, I don't know, then I would probably get a titer, especially if it was like a young teenager that just didn't know what was going on. But you don't necessarily have to get a titer, HSV titer, every single patient. So your UA and culture, that's important just because if a pregnant woman has bacteria in their urine, even if they're asymptomatic, you're always going to treat a pregnant lady, and that's because it can induce preterm labor. You don't want that to happen. No other patient are you ever going to treat a UTI if they're not having symptoms. Blood type and RH. You're going to check that at the very first visit. If they're older than 21, you're going to get the pap smear and then your rubella titer. What happens if the rubella titer is low? So say they're not immune to rubella. Did you give it to them now?
No.
Right. So you wait until they're until they've delivered. So we briefly talked about fetal heart tones. They're initially heard between 10 and 12 weeks. You're going to perform them at every single visit. Normal heart rate's between 120 and 160. If you have an abnormal heart tone during an office visit, then you're going to go onto your biophysical profile. That basically combines fetal heart tracing and an ultrasound. So the fetal heart tracing, you know that you have the two bands. One measures uterine contractions, the other fetal heart rate. In the ultrasound, you're going to look for 5 different components, or 4 different components. And all of these together, each of them have a score from 0 to 2. And anything from 8 to 10, you're pretty much in the clear. If it's less than 6 and they're close to term, then you're going to think about delivery. If they're nowhere near term, then you kind of just have to do what you can, and you might end up giving them steroids and trying to deliver anyways, because that baby's not doing too great. So the 5 components are fetal heart tracing, that's your monitor, you look for accelerations, have a reassuring strip, fetal breathing, movement, muscle tone, and then the amniotic fluid index. You need for the AFI, a 2-centimeter pocket in each quadrant in a vertical fashion. This is it sounds complicated and scary, but a BPP is pretty easy to do once you've had training in it. The next screening test we're going to talk about is called the Maternity 21, cleverly named, and it basically tests the amount of fetal chromosome 21 in the maternal serum, testing for Down syndrome. This test is very accurate, highly sensitive, highly specific, and it can be done as early as 10 weeks, so it's a good test. However, there are some cons. It's super, super expensive. I've never ever used this test. It has been used before, obviously, otherwise we wouldn't be talking about it, but I rarely see it used, and I think mostly that's because of the cost. So if you have Sooner Care, they're not going to pay for this. If you have commercial insurance, typically patients still have to come out of pocket over $200. So, and that's with insurance. So you're probably never going to see this unless the cost comes down. Another con, it's only testing for Down syndrome, and it's not diagnostic, so you're still going to need further testing to diagnose fetal abnormality. Chorionic villus sampling, or CVS for short, is done in the first, or can be done in the first trimester. It's done between 10 and 15 weeks, and it's basically an ultrasound. Let me show you this picture. So it's an ultrasound that uses a needle. You go through the abdominal wall. So you go through the abdominal wall right here with a needle. The doctor probably locally anesthetize this area right here. And you're taking a sample of the placenta, so it's a pretty dangerous procedure. So you come through, this is a chorionic villi, so you're taking a sample of this, aspirating it through a needle, and then you send it off to the lab for genetic testing. Let's see. You can also go through the cervix. Say the placenta is not really close to the surface of the abdomen. If it's lower down, then you can go through the cervix, but you don't want to do that if any fibroids are present. You just don't want to risk hemorrhage. So why would you do this test? If you're advanced maternal age, if you had an abnormal first trimester screen or an abnormal ultrasound, or if there's a significant family history for genetic disorders, you would consider this. Does that always mean that every single patient with these risk factors wants this done? Not necessarily, because this comes with risks. And those risks are miscarriage, which is 1%. 1 in 100 patients that have this done will miscarry. And you just kind of have to discuss that with your patients. Have a risk of infection, and then distal limb defects, and that's just because you can see how close the needle is getting to the potential baby. So say there's something out here, you have a risk of puncturing the limb or potentially making a problem worse. You can also have premature rupture of membranes, and again, as you can see, you could puncture the amniotic sac, and if you did that, then you'd have leakage of fluids, and that could get worse. So like I said, this basically tests for genetic disorders, but this is the only test that you can get to, if you don't know your baby daddy, you can find out your baby daddy through this test before delivery. And this is the only one that'll do that before delivery. Let's see. I have this video, and they do a really good job of explaining what CVS does, so we'll just watch it real quick. It's pretty short.
We'll start with CVS, which can be done sooner.
Sorry, Vaughn.
This procedure is done between 10 and 15 weeks in the pregnancy. In case you wonder, CVS is short for chorionic villus. That is usually just called CVS. This procedure.
Oh, is it right here?
Takes a small sample of the developing placenta, since the placenta is made with fetal cells, we can test these cells for chromosome problems. So let's talk about how the CVS procedure is done. The first thing to happen during a CVS appointment is an ultrasound exam. The ultrasound is used to measure the size of the developing baby, check the heartbeat, and find the location of the placenta. Now, there are two ways CVS can be done. The doctor decides which way is better for your pregnancy by looking at the ultrasound on the day of your appointment. Sometimes the best way to get a sample of the placenta is by passing a thin needle through your abdomen, usually near the bikini line, and into the uterus. The needle doesn't touch the baby during CVS. The procedure can be a little uncomfortable, and some women might feel a cramp when the needle enters the uterus. This is normal, but it doesn't always happen. It can take a few minutes for the doctor to finish getting the sample. In some pregnancies, there isn't an easy way to sample the placenta through the abdomen. In this situation, the doctor will take the placental sample by passing a thin plastic tube through the vagina. This way of doing the CVS is very similar to having a Pap smear. Women usually feel cramping with this method too, but don't worry, that's normal. Just like the other method, it can take a few minutes to finish getting the sample. That's all there is with CVS. For the entire appointment, you'll want to plan on spending about 1 to 1.5 hours at the clinic. But remember, the actual CVS procedure only takes a few minutes. The rest of the time is spent getting you ready for the procedure and having the ultrasound. There isn't much you need to do to get ready for CVS. Before your appointment, you'll need to have all your early prenatal lab work completed. On the day of your procedure, you can go ahead and eat your normal meals and follow your usual activities until the time of your appointment. You might be asked to have a full bladder when you arrive. You're encouraged to bring one support person to be with you during the CVS, but no children, please. Do you have any questions about CVS that you'd like to jot down?
So that was pretty, I thought they did a good job at explaining that. I think that's it for, yep. So now we're on to the second trimester. Like I said, most of your stuff is going to be in the first trimester, but in the second trimester, we're going to get into a little bit of nitty-gritty things. So first thing you're going to do, vitals, urine dipstick, fetal heart tones, every single visit in the second trimester. And the reason I put this up here is because it's so easy, especially with EMR now, to forget even looking at your vital signs. Nobody writes them down. Some people do, but you usually don't see people writing them down anymore. The nurses sometimes are rushing off to get their next patient and don't inform you. So just take your time to look at those vitals. They're really important. I've missed a couple of things by not looking at my vitals. Urine dipstick, you're mostly testing for what? Protein, exactly, for preeclampsia. You can also get blood nitrate, glucosterase on those, but it's mostly for protein. And then the fetal heart tones, remember, 120 to 160. So the maternal serum alpha fetoprotein test, MSAFP for short, which is what we're going to call it today, is obtained between 14 and 22 weeks, but it's most accurate between 16 and 18 weeks. So you have a tiny window to get this test. And it tests for birth defects, chromosomal abnormalities, and can also, no, that's pretty much it, birth defects and chromosomal abnormalities. Mostly for patients, again, that have higher risk factors, family history, advanced maternal age, if they've used harmful medications during pregnancy, if they have insulin-dependent diabetes, those patients are at risk for having fetal abnormalities just because of irregular blood sugars. However, during any pregnancy whatsoever, there's always a 3 to 5% risk of having an abnormality. So that's if you're healthy, normal, don't smoke, don't do drugs, nothing, there's still a 3 to 5% chance. So I offer it to everyone. You probably should too. Sooner Care does pay for this test. So this is really the only one that we use in our clinic. But we're going to go through the sensitivity of it and kind of tell you why it's not the best test. So what is AFP? We don't really know. It's found in fetal serum, amniotic fluid, of course it's in mom's serum. We don't know what it does, but we do know that we see a hike in it during pregnancy, and that hike usually peaks around end of second trimester, early third trimester. So that's why it's really important to hone in on those 16 to 18 weeks to get this test. It's measured in the multiple of the median, and that's basically a big fancy word saying that they can take into account the level of AFP, they take into account mom's age, and her other risk factors, and compile that into a number that kind of gives you a risk for her. If the test is abnormal, only 2 or 3 babies out of 100 will have a birth defect. So it's not a very good test. That's very, very poorly specific. And just kind of a fun fact, it's also elevated, AFP is elevated in liver carcinoma. So if you have a mom that has, I don't know, a liver issue, it could potentially be elevated from that as well. So reasons, so AFP can be high or it can be low. Reasons it can be high are primarily defects that expose parts of the body to the outside world or the amniotic fluid. So neural tube defects, spina bifida, where the spinal cord is exposed to the amniotic fluid, anencephaly, where the brain isn't completely formed and it's exposed. This is a picture of omphalocele, where the abdominal wall contents are outside of the belly. Gastroschisis, same thing. Abdominal wall contents are outside of the belly, it just doesn't have a covering on it. It can also be high in placental abruption. If you have twins in there, of course it's going to be high, right? Because you have two babies that are producing it. And then liver disease in mom. However, the most common cause of having a high level is inaccurate dating. So again, 16 to 18 weeks, I'm going to try to make sure that you're in that window. Pretty poorly specific, 85%. If you add this with ultrasound, it bumps up to about 95%. So if you have a high AFP, you're just going to send them for an ultrasound. Low AFP is a little bit easier to remember. Just remember chromosomal abnormalities. So Down syndrome, Edwards, other abnormalities. Unfortunately, this one is even less specific, less than 40%. So you're going to send them for an ultrasound off the bat. Just remember in your diabetics, they might have an abnormal value. That doesn't necessarily mean that it's a bad thing, especially in insulin moms, insulin-dependent moms. They usually have less than 20% less than the general population of AFP in their serum. So let's see. So if it's high or low, like I said, send them for an ultrasound. Usually I send these patients for genetic counseling as well. In my 15-minute slot, I don't have that much time to go over every single detail with the patient, so send them to the genetic counselor. They have more time, and they're probably better at it than I am, since I don't do it very often. You can also repeat the test. So say you get your ultrasound back. Mom's actually 14 weeks. She's not 16 or 17 at all. You can repeat the test whenever she does become 17 weeks and see if it normalizes then. Other options are amniocentesis and then further testing, which is what we're going to talk about now. So the triple screen, you're going to get it in between the same number of weeks, 16 to 18, and it's basically just what it says. It's using your AFP plus 2 other markers, which is estriol, or unconjugated estrogen, and human chorionic gonadotropin. I won't go into too much detail about these, but just know that the more substances you add to your screen, the higher sensitivity that you're going to get. So this one bumps it up to 70%. It doesn't really make a difference for neural tube defects, abdominal wall defects, because you can see that you don't even care about those. You're just going to use the AFP because it's going to be high, and then you're going to get your ultrasound, and that's going to bump it up, the sensitivity up to 95%. But for these other, trisomy 21, trisomy 18, it's going to bump up the sensitivity and kind of tell you more of, is this Down syndrome or is it something else? Same thing with quad screen, the only difference is that this one adds inhibin A. Turner syndrome, I added on here. You can have a super high inhibin A and HCG and low of the other two. And it kind of mimics trisomy 21. Same thing, you're going to get an ultrasound. The bad thing is, all of these tests have a 5% false positive. So that's a pretty big number. That's 1 out of every 20. That's going to put mom through undue stress, undue anxiety, undue testing. So again, triple screen, quad screen, I don't offer to everyone. Sooner Care doesn't pay for those for everyone. You just kind of have to discuss those with your patient. So like we talked about, age is your baseline, and then you add all of these other tests, you're going to get your increased sensitivity for detecting Down syndrome. We've been talking about ultrasound, and you all know what that is. We say level 2, that basically just means it's an anatomy scan. So let's talk about it for completely normal pregnancies. You typically don't get one during your first trimester. You can for dating purposes, but it's not absolutely necessary. Even if mom doesn't know her LMP, you can, but it's not necessary. So when mom's between 18 and 22 weeks, you're typically going to get this. And that's just because you can see organs better. You can see the sex of the baby. You can just see everything better. And it's basically all evaluating for the growth and development of the fetus. So you're checking the size, checking the heart, lungs, liver, diaphragm, bladder, kidneys, making sure all of that's normal. Umbilical cord, seeing if they have 3 vessel or 2 vessel cord. You can tell the sex if you want. You're going to check the heart rate, AFI, and checking for the placenta. So some mothers decide to forego all of that previous testing and just wait until we get the ultrasound, because that pretty much shows us a lot of abnormalities already, and they don't have to go through that testing. And like we talked about before, adding the ultrasound to a high AFP increases your chance of catching a neural tube defect, abdominal wall defect. Okay, so amniocentesis, it's similar to chorionic villus sampling, so I don't have a video on this. It's pretty much the same, except you are testing amniotic fluid for genetic deficiencies and not placenta. This one you're going to get in between 14 and 18 weeks. Again, you have your risk factors there: AMA, any prior siblings with birth defects, and abnormal testing or ultrasound, any family history. This one is a little bit less risky. Your risk of miscarriage kind of varies. There have been multiple studies. One study said 0.06% of a miscarriage, which is really, really low. The other one said between 0.6 and 0.8%. So I put that range in there. It's less than 1%, which is better than a CVS. Anytime you puncture anything in that little belly with the fetus growing, you're at risk for preterm labor, you're at risk for infection. So there are still risks, it's still invasive, but it's a little less risky than a CVS. If you progress into your 3rd trimester, you haven't needed this since then, you can also use amniocentesis to check for fetal lung maturity. If you're thinking about delivering, you can check for congenital infection, and you can also check for hemolytic incompatibility. And then the one thing I didn't put on here is that if you have polyhydramnios that's becoming a problem, you can also use amniocentesis to pull off some of that fluid. Our next one is portocentesis, or another long word, percutaneous umbilical blood sampling, or PUBS for short. So you can perform this pretty much any time after 17 weeks. Again, similar procedure, using an ultrasound to take blood, fetal blood from the fetal umbilical cord. And this one's a little bit higher risk, so I've never seen this done before at all. I didn't have to work in the NICU. I'm sure if I did work in the NICU, I would have probably seen it more. But you have risk of infection, bleeding, miscarriage risk goes up to about 2%. You can have premature rupture of membranes, and mom typically has to stay in the hospital. And then fetal bradycardia, just because you're messing with their umbilical cord. So that heart rate goes down to 50 or so. You got to be really careful and potentially think about delivering if you're close to term. Again, use those as a last resort. So let's start talking about things that you're going to do in every normal pregnancy. The glucola test is done between 24 and 28 weeks. Test for gestational diabetes, and you're going to take 50 grams of glucola and swallow it. It's like maybe about that much, really tiny cup. You ingest it, you wait an hour, they test your blood. If it's over 140, you're kind of in trouble. If it's less than 140, you're good to go home. So if it's over 140, you're going to need a diagnostic test, which is the 3-hour glucose tolerance test. Same thing, same concept. You're just going to ingest a higher dose of glucola, 100 grams, and then you're going to have your blood drawn 4 separate times. So one when you're fasting, one at 1 hour, one at 2 hour, and 3 hour. And then you have to have 2 abnormal values to be blessed with a diagnosis of gestational diabetes. So greater than 95 fasting, greater than 180 after 1 hour, greater than 155 after 2 hours, and then greater than 140 after 3 hours. Pretty much after that, you're going to have nutritional counseling, and depending on the values, you might need oral medication or even insulin. And so you're going to do this test on everybody. Rh negative patients. You got to remember this, between 24 and 28 weeks, they get RhoGAM, period, point blank, nothing else to do. You can retest the Rh, but you don't have to, I never do. I just give them RhoGAM. And then remember, any risk of bleeding or any bleeding during their pregnancy, they're going to get that RhoGAM too. So if they have a CVS, if they have an amniocentesis, you're going to want to give them RhoGAM prior to that procedure. Anemia, this is normal pregnancies. So between 28 and 32 weeks, you're going to recheck an H&H. You could get a CBC, but an H&H would do just fine, even though you might want to check their platelets. So disregard that, just get a CBC. And again, this is in preparation for delivery, so you're checking for anemia, you're checking for thrombocytopenia. If they have higher bleeding risk, you don't want them to hemorrhage and need blood products, so you're trying to get this up, build up their stores before they deliver. And we are almost finished. So we're into the third trimester, and there is only one test, except for your vitals, your dipstick, and fetal heart tones. And that's the GPS swab. So that's done in between weeks 35 and 37. Any earlier than that, the test doesn't last up until delivery, or potentially doesn't last up until delivery. I can't remember exactly how, do you remember? 4 weeks?
Or after,
Yeah.
or how long the test is good for?
Yeah,
It is 4 weeks.
4 weeks.
And repeat it.
So, so say you got it at 34 weeks and they deliver at 40, you're gonna wanna repeat it at 38 weeks. So getting it right between 35, 36, 37 is gonna put you in the clear. And this GBS is group B strep, bacteria. 15 to 40% of women are colonized in their urogenital tracts. Doesn't cause any problems if they're not pregnant. And if you're pregnant, there's a risk of transmission to your fetus during delivery, and that can cause sepsis. Don't see this a whole lot now due to the advent of antibiotics. So if your patient is not allergic, they're usually going to get penicillin every 4 hours until delivery. If they're allergic, they can get clindamycin. But sepsis in neonates is not fun and not pretty. Early is considered less than 7 days. So just because you send that baby home and they're looking great from the hospital doesn't mean that they can't potentially not look great a week afterwards. So just usually if there's a concern, or say mom didn't have the test done, say she's a drop-in, she didn't have any prenatal care at all, I would give them antibiotics just because we don't know. There is an algorithm, I don't have it completely memorized, but you can find it on the website, GBS, and it kind of goes over risk factors and when to treat, when not to treat. So I'll leave you with a fun picture. This is the GBS swab. So you're going to insert the swab. It looks like a normal swab that you would use to take an abscess culture or a throat culture or anything else. You're going to place it in the vagina. And then I swab down to the anus. I don't actually put it in the anus, but I just kind of swab down the urogenital tract and then send it off. But the true test is to place it in the vagina and then place it in the anus as well, and then send it off for testing. I think that's it. Any questions?
Is the fetal heart tone the same thing as a fetal heart rhythm, or are those different?
Yes and no. So fetal heart, good question. Fetal heart tones are basically used with a Doppler. So you can have your portable Doppler, and it uses ultrasound, but you just place it on the mom's belly and you just hear. That's what so fetal heart tones is what you hear. Fetal heart tracing is what you see whenever you have the two belts, and it traces the A cells and the B cells and how the heart is moving. Any other questions? No? Thank you for having me.